Now that we are within our first meeting of this fall term, if you are a committee member, please turn your camera on, as I will take roll or just say here if you're not able to. But first and foremost, can people hear me?
Yep, we can hear you, Enrique.
Perfect. Thank you, Ali. So I'll just take roll call to make sure we have quorum, and then I'll make a request a motion for adopt the minutes that you were sent by Rose, and then adopt the agenda for flexibility. I just want to make sure I have quorum. Is Dr. Andrea Lara present? How about Dewberry Michelle?
Michelle said she wasn't going to be available today, Enrique.
Okay, thank you very much. And Sally? Lucy Bonnie? Or Louis Bonnie? Tony? Susan Miller? How about Misty?
Misty will be out as well, Enrique.
And how about Mr. Robert Young?
I'm here.
You're here. All right.
And then
we'll wait for. Go ahead, Ali.
Bill Gropp actually is also still technically on the board, and he just texted he has some technical issues. He just got knocked off, so he's jumping back on. So yeah, it looks like we're going to need to wait on minutes so other people join.
Yes. So we know we have Robert and Bill will be joining soon. Michelle is not going to be able to be present. So we'll just wait for a couple minutes. So if you have time, you can put your elevator music on for a little bit. I will not put my elevator music myself, but I'll look for anybody joining the meeting. I see someone joined the group, and Bill, are you here? No. I can't hear you, Ali.
Yeah, sorry. I can go ahead and start. Yeah, if you want me to start up on the first agenda item.
Go ahead, Ali. You can start with your director's report.
Yeah, you bet. There's Bill. Yeah, first, yeah. Yeah, first, I just wanted to welcome OEBB board members back from the summer break. It's obviously a really super busy time for everybody, and we really appreciate the participation as we start the fall season. And we typically like to keep this September meeting on the light side and then hit some of our heavier topics in October, which leads us into our in-person retreat into November. So I'd like to provide you with a couple of updates before we jump into the agenda. First, we're getting a couple of new OEBB board members, which is, partially why we're short on board members today. But the governor's office just released the list of names that are up for Senate confirmation at the end of this month. And the first new OEB board member is a very familiar face to all of us staff on the board, and Bill Gropp, who we're super excited to learn that Bill is moving at the end of this month from his current school board seat to the local government non-management seat, which we've had a real tough time filling over the years. So that's pending confirmation by the Senate later this month. I think it's September 28th or 29th, Bill. But Bill is actually the first OEB board member to change seats after serving a full 2 terms, which says a lot about how much he cares about contributing to the OEB board success. And he obviously brings a wealth of experience and knowledge onto his new position. So we're again very fortunate to see Bill continue on the board. Bill, is there anything you would like to say?
I'm happy to serve, as always.
We're happy you're here, and thank you again, Bill. So next, we have an extremely well-qualified candidate that's up for Bill's previous school board position, who will be confirmed by the Senate at the end of the month. Probably better to wait to mention the name, but since they'll be new to the OEB board, we do plan to do a full introduction at the October meeting once they're confirmed. So would also like to mention that Cheryl Berger, our local government management board member, retired over the summer. So that's our one vacant position on the board that we're looking to fill. So my next update is just a quick one on open enrollment, which started earlier this month. And we have our staff and the staff of our carriers really traversing the entire state, working with our OEB members and their families, and as well as educational entity staff members. We're working to get our 160,000 employees and their dependents enrolled. So, as you know, there are several changes to plans from this for this upcoming plan year. So also implementing the new Garner Health Incentive Program. So on the ground, just from the first week, the themes that are emerging are really less questions about the plan changes or Garner, and more focused on members understanding the plans to enroll in, since they haven't enrolled in a couple of years. So not all of them have enrolled. But in really just helping them do some plan comparisons, what their contributions would be, and people really seeking to enroll in the best plans for themselves and their families, given their personal situations. So this is where our webinars, our open enrollment tools, and really just want to mention the incredible allocation of resources from our insurance carriers is really stepping up to the challenge. They're all out there working with people and doing whatever we can to make sure that people are making informed choices. So we'll have a much more comprehensive open enrollment report for the board once the open enrollment period is closed and we have a chance to look at enrollment data and get some surveys out there to really learn more about how we can best support our members. So that's my 2 updates for now. If we have any questions.
Any questions for our executive director? All right, Allie, I guess we can proceed to our next agenda item.
Yeah, thank you. Yeah, so we'll bypass the minutes. We knew we were going to have a tough time getting a quorum today, but hopefully some additional board members will jump on. I can go ahead into the budget update. Rose, thank you. Go ahead and go to the next slide, please.
I just wanted to let you know I missed attendance, but I'm here. This is Sally. Sorry.
Oh, thanks, Sally.
Welcome.
No problem. Okay. So today we'll be focusing our semi-annual budget and financial update on three different areas. We'll look at the status of OEB's 2023 through 2025 legislatively approved biennial budget, which just concluded in June, as of June 30th. And second, we'll take a historical look at our claims paid over the past 4 years and how it's impacted our funding position and our funding model overall with MODA. And then third, we'll take a look at our cash reserves, also known as our stabilization funds, which we'll talk about more today as well as in the upcoming renewal. Next slide, please. Oh, sorry, my bad. Previous slide, Rose. There we go. So kicking this off, let's look at our 23 to 25 biennial budget status. So this report is through, again, June 30th of 2025, which is 100% of the way through the biennium. Just as a refresher, the state budgets on a 24-month period from July 1st to June 30th of odd-numbered years. And July 1st actually started a new biennium, the 25 through 27 biennium. So on this slide, you'll see our two budget structures, the stabilization budget, which is over $2 billion, and the operations budget, which is about $22.2 million. So about 99% of our budget is in stabilization fund and 1% is in operations. So the stabilization fund budget captures all expenditures going out to carriers for benefits and claims costs after bringing in premiums from participating entities and self-pays like retirees and COBRA members. As you know, we actually invoice our participating entities every month. We reconcile enrollment and payment from prior months, and we come up with a final invoice, and then we reconcile with our contracted carriers, and we either reimburse claims or we pass through premiums. The operating budget captures expenditures for staff like personnel costs. We also pay out consultant costs, which is, Mercer is our largest operating budget expense. We also pay out system maintenance and development costs for our eligibility and enrollment systems. And things such as open enrollment costs, our attorney, Department of Justice costs, as well as a myriad of other things. As you can see in the stabilization fund chart, through 100% of the biennium, we actually did overexpend our budget by about 0.3%. The reason for this is higher claims payments and higher number of enrollments covered by OEB. The budgets are set at an aggregate dollar amount, so just say $2 billion. So any increase in enrollments means there's more dollars actually moving through the system than anticipated when the budgets were set 2 years ago. So those dollars are captured as expenditures, which count against our approved budget. So the OEB board, you all are accountable to a 3.4% maximum premium increase per employee per month, PEPM. So that's really the budget that you're accountable to. The 3.4% PEPM is how this budget performance is measured and reported to the legislature and the governor's office. So the board, you all have met this every year. So our aggregate budget, the $2 billion, is really how they just set that total dollar amount. So again, I think, with the significant increase in budget, that's what kind of pushed us over that top limit. But as far as meeting the 3.4% budget, then the board and we're fine as a program. So with the operations budget, we expended about 92.7% of our biennial budget, so we landed a good 7% under budget for the biennium. Any questions on that slide? Okay, next slide, please. Okay, so slide 3 is our MOTA dental. This is our cumulative claims liability, and that's very technical. I'll try to explain that as best as possible. But on these next 2 slides, we'll take a look at the MOTA dental and MOTA medical claims fluctuation over the past few plan years, and take a partial look at the 24-25 plan year through 9 months as well. We're only looking at the MOTA plans today. You may remember that Kaiser plans are a more typical fully insured plan and funding model where OEB, like I mentioned, we invoice participating entities who have Kaiser employees, and then we pass through those premiums to Kaiser. This is much different than what we have with MOTA, which is a minimum premium funding model for our medical and dental plans. So I'll walk through the mechanics of this model, but please feel free to stop me and ask any questions. And Kirsten from Mercer, feel free to add any comments as well. So starting with this, with the MOTA dental claims on this slide, you can actually reference the 2 bars as the maximum claims liability, which is in a minimum premium arrangement better known as the premium. And then the next bar over is the gross adjusted claims, which are the total claims paid net any adjustments. So for example, if you look at the 2021 plan year, we collected more in premiums than we paid out in claims, which resulted in a $5.3 million surplus, which is what that line represents as that claims liability balance. So this balance represents the ending balance for the year. So dental, in fact, a surplus was realized in every year on this chart for dental. So, and then so far for 24, 25 through 9 months, we're actually in a slight surplus as well.
Lee, can I ask real quick, just looking at the graph, should we be shooting for, or what I'm getting out of this, we should shoot for something like 22, 23, where it's not negative, obviously, but close? Or should we be shooting for something with a higher surplus?
Yeah, I think the goal would be, I guess, to have it is not be billing for premiums that would exceed. You want the premium billed and the net expense to align. Now, having a surplus obviously is a much better thing than having a deficit for a year. And for dental, the board has experienced a surplus in every year, even through so far this year. But yeah, I mean, you're right. I mean, it's a great comment. I do mention this as well for the PEP board, which are mostly self-funded plans, is ultimately you want to project out and have whatever premium you're billing your entities and your employees to not be too much or too little, but to be right on the money. But as you know, that's really more difficult when you're setting those rates so far in advance of the plan year.
And I think too, Robert, so the minimum premium contract, it's a really interesting contract. It's like a fully insured contract. So it's similar to Kaiser in that, if OEB experience were to consistently come in higher than premium, and then really the minimum premium contract, the funding type matters more like at the termination of the contract between OEB and MOTA. If OEB were to terminate with a big deficit with MOTA, OEB would not be responsible for paying that deficit, just like in a fully insured situation. On this slide, the maximum claims liability is actually, think of that as a portion of the total premium. So when we do the renewal cycle every year, the board approves the premium rate. And the premium rate includes a portion for claims, like 90% of the total premium is for claims, and 10% is for expenses. The maximum claims liability, that's essentially the claims budget portion of premium. And so every month, OEB is invoiced for actual claims, and MODA's accounting department does this accounting for the minimum premium contract. So every month, the premium is paid to MODA, and MODA will compare the claims portion of that to actual claims paid. Sometimes the actual claims paid are lower than what MODA has set aside for claims. Usually that's a seasonality thing, right, for OEB. Typically, it's very difficult for teachers to go back, and also the accumulators have reset right at the start of the school year, our educators and assistants, excuse me. And then over the summer, even though I know folks do often work over the summer, there might be a little bit more schedule flexibility to have surgery. So we tend to see actual claims come in lower than the claims budget at the beginning of the plan year. And so this cumulative balance increases. And then as we go into the summer months, it kind of reverses. And to your point, two things are happening simultaneously. Yes, we want our claims to come in at 100% of the target. Ideally, right? Because we don't want OEB members to be paying any more than they absolutely have to. And we try to do our best through the renewal process to project that. Of course, healthcare expenses never do what we want them to do. And so they always come in a little bit different. But ideally, the claims budget and the actual claims expense are the same. There could be some reasons, like for dental, for example, some reasons why we're consistently a little bit over on the dental. And that's something that we reevaluate with MODA every renewal cycle. We do have this history to say, you know, hey, MODA, we see that we have consistently been growing the cumulative liability balance. Let's see if we can be a little bit more aggressive in the renewal and try to get down closer to 100%, because of course, that helps us achieve our 3.4% target easier. Also, it's better for our members to not be paying premium they don't need to pay. But at the end of the day, we do try to make sure that we are adequately funded, because we do not want to set ourselves up for a tougher renewal the next year than it already is. So sometimes that leads to a little bit of unintended conservatism, and you're seeing that reflected a little bit here in the dental.
Thanks so much, Kirsten. Mm-hmm. All right, moving on. Next slide, please. All right. So consistent with the last slide, with dental, we're comparing medical claims versus premiums. And you'll notice that we had a surplus from years 2019-20 through 23-24. And as you can see, that has changed in the 24-25 plan year, where claims have exceeded premiums by 22.6 million. This is really, a reflection of the trend that the board was wrestling with during the last renewal. We'll hear more from Kirsten Mercer at the retreat on what the future trend is looking like. But the key takeaway here is the pandemic moved OEB into a reserve surplus position, which has continued through this year. So the premium funding model is doing really well, but obviously with the rest of the marketplace are really running into some headwinds this year and next year. Anything you'd like to add to that, Kirsten, or any questions on that slide?
Yeah, as we get further into the day, the OEB new plan year kickoff discussion with Mercer towards the end of the afternoon is really going to touch on this idea and put OEB's results in perspective with what we're seeing with our other commercial clients. And John has some specific information he's going to share to help put this in perspective. And I know, Ollie, you're coming up on a slide here that shows the total balance. So yeah, as we head into that slide, that balance is going to look large. But what I want OEB, this is just a really good illustration for how much claims can swing from plan year to plan year. So in the 24-25 plan year, that's cumulative stabilization balance for medical swung about 23 $23 million. So just keeping in mind that there's big dollars here. So we'll see a big balance, but also there's a lot of volatility month to month plan year to plan year that can be big dollars as well.
Thanks, Kirsten. Okay, next slide, please. This is our last slide. So this last slide shows our reserve cash balance reported through June of 2025, which currently sits at $84 million. And this is a $10 million increase from my reporting 6 months ago. It's mainly comprised of two pots of money, the rate stabilization reserve funds, also known as the RSR, at $18.4 million, and then the OEBB stabilization reserve at $65.6 million, which has slowly been built up over the years with interest earnings, administrative budget savings, and then some federal investment funds from several years ago. The RSR reserve was generated from the Senate Bill 1067 hospital cap savings. The RSR and the Stabilization Fund Reserve is much different than the medical and dental cumulative claims liability balance of $87.7 million, which is noted at the bottom of the slide. This is what Kirsten was talking about, where the cumulative claims liability balance is in a surplus position right now, but it can fluctuate dramatically. As Kirsten said, it's big dollars, and month to month is subject to going up and down considerably depending on experience that month, or even weekly. But it's also subject to paying any claims run out upon termination of the contract, and so it's essentially a running balance that carries over into a new plan year, and we continue to keep you updated on this number, this reserve. But for key takeaways, I would say the board is in really good financial position. It's about as good as it's ever been, maybe other than this previous year. But this past year has eaten into some of that surplus reserve. But with that, the actual stabilization fund, the RSR, and the stabilization fund reserves, that's never been higher. So with that, I'd be happy to entertain any questions or any other comments, Kirsten.
No, that's great, Ali. Thank you. Maybe I'll add one thing, which is we talk about these different surplus accounts as part of the renewal cycle. So we'll hear more about these and their different function within the renewal process in December with our renewal cycle kickoff, and then in more detail next spring as we gear up for the 26-27 renewal.
Perfect. Thank you so much.
So that will bring us to the next agenda item, correct, Ali?
Yes.
Yeah. So that'll be Margaret and Kristen.
Yeah, good afternoon. Thanks so much. Kirsten and I are going to kind of tag team on this presentation. I want to note up front that this is an action item on the agenda. However, in light of the fact that we don't quite have a quorum, the board can defer action until a future meeting. So we will go ahead and walk through the slides, and happy to talk through any questions. And then, we can carry forward as necessary any remaining business. So again, just for the record, I am Margaret Smith-Isa. I am I work in program and policy for both OEBB and PEB. And one of the key areas the program and policy unit works on with our colleagues in contracting is around performance guarantees in our carrier contracts. And specifically today, we are looking at the medical contract performance guarantees, specifically the guarantee that's in place related to cost trend, cost and premium and plan cost growth. So kind of stepping back, quick refresher I think most board members are probably familiar, but it's always good to kind of recap where the medical plan performance guarantees stand. The performance guarantees in the medical contracts currently carry across 3 different areas of plan performance. And the goal is to really place dollars at risk with our carriers for key priority areas of the board, areas where we really want to drive performance, improve service and outcomes for members, member experience factors in as well. So high level, in total, OEB contracts for each carrier have 15% of the administrative fees that OEB pays. So these are the administrative fee portion of the premium rate, not the claims dollars. But 15% of those administrative fees at risk, divided across 3 areas: behavioral health, clinical performance, and financial. And so really quickly, kind of as summary on behavioral health and clinical, because we're not specifically looking at outcomes related to those 2 today. But on the behavioral health guarantees, these are new guarantees that were added in 2024. So relatively new to the benefit plan contracts. And the first year contract, we're really just working on pay for report on these behavioral health measures. So have not yet set specific targets, but fees are at risk for carriers tracking and reporting this information. The metrics that are involved in the guarantee include metrics around behavioral health appointment wait time, time and distance standards in terms of access to providers, provider network diversity, and then provider network directory quality, and then also a guarantee, some fees at risk related to an improvement plan that carriers have to submit based on their identification of specific improvement actions they're going to take in one of the reporting areas. The behavioral health guarantees were developed in the innovation work group last year, incorporated into the contracts, and we've just recently gotten the first year of reporting on these guarantees. So CIAO will be reviewing that information later this fall, having some discussion around it and identifying potential next steps and recommendations for the boards to carry forward to future contract years. On the clinical guarantee, again, this is 5% of fees, 5% of administrative fees at risk, and it is specifically for clinical health plan clinical performance measures. These are generally clinical quality and outcome measures. We use HEDIS measures, which are longstanding, nationally vetted and benchmarked measures of plan performance managed by the National Commission on Quality Assurance, NCQA. So again, the goal is to ensure that carriers' clinical care management is aligning with the board's clinical priorities and driving improvements in member health. These clinical quality performance guarantees, this one has been in the contract for a number of years. And again, every fall, CIAO reviews performance and identifies any opportunities for refinement or improvement or revision to the guarantees for contracting. So CIAO will be taking a look at these measures next month at their October meeting. And just in terms of specifics, the measures really look at metrics such around immunization and screening rates, preventive care, things like cancer screenings, some measures specific to chronic conditions in terms of like hypertension management and diabetes care. So that's kind of the type of measures this guarantee involves. And again, CIAO will be doing a deep dive on those next month. So today, the results we have to report are related to the financial guarantee in the medical plan contracts. And this guarantee places up to 5% of plans' administrative fees at risk, essentially for plan performance aligned with the 3.4% cap OEB has to meet in terms of year-over-year plan cost growth. And so specifically, the plan looks at a year-over-year premium increase for Kaiser, year-over-year plan cost increase for MODA. And if the plan's increase in cost falls between 3.4% and up to 4%, then their penalty or fees at risk, penalty due to OEB, is 2.5% of their administrative fees. If the cost increase is more than 4% year over year, then they pay or they are due to remit to OEB the full 5% of administrative fee penalty. Now, if the plan maintains cost growth year over year at less than 3.4%, there is no fees at risk due, and the plan retains all administrative fees. So I think we can go ahead to the next slide. And this one just kind of shares the results. So we're talking specifically about the 23-24 OEB contract year. So we're looking at the cost increase from that year versus the prior year for that contract year. And in terms of the final results, both carriers exceeded that 4% kind of ceiling we put on the risk corridor. So Kaiser came in at 5.7, MODA's measured at 7.9, and you can see the penalty amounts there in the next column due from each carrier. So almost $2 million from MODA Health and a little over $700,000 due from Kaiser. And the previous contract year, the 22-23 contract year amounts are in the next column for reference. And you may recall that last year, the board, in terms of settling that penalty, applied those fees at risk due as a credit to renewal rates during the renewal season. Next slide. Just to share a little bit more about the broader context, we do look at this as part of OEB sort of operating in the broader marketplace, the healthcare ecosystem in this country as well as in this state. And I do think it's sort of interesting to note or share, we certainly track closely this statewide healthcare cost growth target program. That is a program managed within the Oregon Health Authority that looks at cost growth in the healthcare system for plans and providers on kind of a global basis, looking at market segments. So overall cost growth, commercial plan cost growth, Medicare and Medicaid cost growth. And just this slide just has some highlights from that report. For it was recently released looking at 2022 to 2023 cost growth. I want to point out that this particular report, which is the most recent data available from that program, doesn't quite align with the OEB plan year cost growth that we're looking at for our performance guarantee. But I think it does still tell part of the story in terms of what's being seen in the commercial market overall. And so what the Healthcare Cost Growth Target Program found in their report was that statewide cost growth was 5.2% on a per person basis, which was higher than observed in previous years. And total medical expenses for the commercial market grew 6.3%, and that's an unadjusted 6.3%. No commercial payers in this report met the statewide 3.4% cost growth target. And there's a lot of detailed data within the report. The link is at the bottom of this slide. If you're curious to look, the report does note that Kaiser's commercial cost growth, they kind of classified it as indeterminate, meaning that the 95% confidence interval for that included the 3.4% target. So that is just some further context for the board to consider as we, think about how OEB plan costs are trending and kind of how OEB fits into the broader commercial market in that regard. Next slide. All right, and I think Kirsten was going to talk a little bit about next steps. I think recognizing that we would likely not have a decision today, we can answer some questions, and then determine, how to carry forward from there.
Thanks, Margaret. We have two options, board, for you to think about. The first option is the one that we've historically taken together, and that is to apply the trend guarantee penalty credit towards the renewal increases for Kaiser and Moda. Those usually get applied right at the very start of the process in round one. There's a reason for that. Of course, that would only happen if the renewal increases come in higher than 3.4%. And then option two, the board also has the option of asking the carriers to deposit the surplus or the credit into the rate stabilization fund. The rate stabilization fund, I mean, honestly, if we think about prior historical renewals where the situation arises where our final round 3 renewal is greater than 3.4%, maybe some of you can picture this, picture these slides we normally look at, but we're sitting there all together in March and April of next year thinking about, okay, we have a renewal increase of 4.3%. We need to achieve 3.4%. How can we do it? What mix of efficiencies or plan changes or buy down from RSR would we like to use to achieve 3.4%? So in a sense, applying the credit at the beginning of the renewal process essentially gets us to the same place as adding it to the rate stabilization reserve and then using the rate stabilization reserve to apply it to the renewal increase at the end of the year, just with a lot more administrative work and lack of transparency too. And maybe that way means that we have to talk about benefit changes that we wouldn't talk about if we applied it at the beginning of the process. So Mercer's recommendation would be if the renewal increase for round 1 comes in higher than 3.4%, we're going to talk a little bit about that more later, that the board would ask the carriers to apply the credit to the renewal right at the round 1 renewal increase. So we could see that the renewal increase after it's already been lowered for the credit, and we know better where we're standing. I know sometimes as a board in the past, we've talked about, well, does that reduce the carrier's incentive to negotiate competitively with us during the renewal process? And the due diligence that goes on with the renewal process. So as you guys know, we spend January, February, March, and April with you going through the renewals, round 1, round 2, and then the final round 3 renewal increases in great detail with you. The premium rates that get calculated for Moda and Kaiser really don't have any place or opportunity for the carriers to just add this in. Part of the due diligence process says, hey, we can replicate this renewal calculation and make sure it's reasonable because it's 90% claims, which can be verified, and then it's 10% expense load. And we can do a due diligence check on that as well. So there really isn't an opportunity for Moda and Kaiser to just not be as competitive or somehow sneak it in the renewal without being caught. So it's maybe the simplest for the board and also is going to lead to the most transparent renewal conversation and avoid talking about changes that we don't need to talk about if the credit were applied, if we just simply ask the carriers to do that right out of the gate. I know we don't have a quorum today. We're just giving all of this information for consideration and then also give you all an opportunity to ask any questions that you have about this process. Yeah, go ahead, Bill.
Well, as the longer term board members will know, for the last 2.5 years, I've championed option 1, battling Dr. Siltabo and others, down this path. But it is to me, the best way to acknowledge what's going on and how to handle the flow of cash here. Also, I think, in my opinion, what's going to happen to healthcare costs this year, which is going to be my question after we're done talking about this, which is the Medicaid changes that are coming. This would be the best way to handle this. I thought we had 6 board members online, but maybe not.
I only have 3 right now.
We have 5 total.
Oh, it's 5. I thought I counted 6.
We need
Okay.
We need 6. Yeah. But,
I know. That's why I
which-
said I thought I counted 6. Right. So, okay. Anyhow, yeah.
I guess if we get to 6 throughout this afternoon, what I would ask if it's okay with staff and Ali to revisit this topic so the new board member can get an up-to-date information so they feel that they have all the information necessary to take an action item if we have full quorum.
Absolutely. Okay.
That's it for this presentation, Rose. I think we can go on to the next one. Thank you.
And the next will be our.
But can I follow up on that question I was going to say, and which is what's Mercer's expectation on when the Medicaid changes are going to start affecting state healthcare costs? Like how long it's going to take for it to munch through the whole system and start affecting overall healthcare costs?
Bill, if you don't mind, in the new plan year kickoff discussion later in the afternoon, part of that conversation includes some discussion around the question that you were asked. Yeah, would it be all right to wait?
Yeah. I just didn't see that in the packet. Okay. Yeah.
Thank you. And this is Sarah Drake from Mercer. Sarah, are you available?
I am. Can you hear me okay?
Okay. Yes, thank you.
Okay, so the purpose of this topic is to talk a little bit about the work that we've done in the CO Summer Research Group. And just as a reminder for the group, these are the overall goals of OEB. High quality, affordable care, to continue to grow OEB, to reduce out-of-pocket expenses for members, to explore potential RFP, and then to continue to improve member education. So we kept this framework in mind as we worked through the CO Summer Research Group with the PEB team. We go to the next slide. Just as a refresher, this is our 3rd year of having a summer research group with CL. During the first year, we looked at doula coverage, and then also we did a deep dive into drug coverage for weight management, including, but not only including GLP-1 medications. The result of that first summer research group was the addition of doula coverage for OEB in the 2024 and 2024 plan year, and it ended up being added also for PEB in the 2025 plan year. Last summer, we did a deep dive on traditional health workers. And what we learned through that research and some due diligence is that there is current coverage availability for traditional health workers under the OEB's plans. This year, we kind of went back to more like traditional medical clinical focus and really looking at type 2 diabetes and what kind of information we can gather to really optimize treatment outcomes for people with type 2 diabetes. So let's go to the next slide and we can talk a little bit more about how we selected that topic. So I think, as you know, when we've shared some data in the past, diabetes treatment is one of the fastest growing categories of prescription drug spend. It's not unique to OEB, but we certainly do see that in the OEB data. One of the things we've also seen in the OEB data is that there are pretty significant differences in prescribing patterns across Kaiser Permanente and the MODA network. And so we went into the summer research group really wanting to understand how can we use the information that we have to better understand how we can achieve the best outcomes for people with type 2 diabetes. And so our intent was to review current outcomes across Kaiser and MODA. We were focusing on the hemoglobin A1C. And the A1C is a lab test. It's commonly used as a standard of care in diabetes. Most people with type 2 diabetes have that taken about every 3 months. But using that as a measure of how is the different treatment approaches, how are the different medications working to improve that lab value for people who have diabetes. Now, we know that the A1C isn't a perfect measure, and we've talked about that in depth in the summer research group and in CAL, but it is easily available in the data, and we thought it was really a good place to start to best understand where we are with prescribing and with diabetes treatment. So let's go to the next slide. So this slide talks a little bit about what was our process for the summer research group. So it was a collaborative effort. We had Mercer as well as a representative from each of the carriers for both OEB and PEB. We had staff and then also OEB and PEB representatives participate as part of that group. We really did a deep dive into type 2 diabetes. We talked a lot about the different lab values, the different treatments that are available, and how we might best measure. It was an iterative process. We had 3 work group meetings. We started with just introducing the topic, talking through what a proposal might look like. We solicited feedback from the carriers, from the staff, and from board representatives. And I have to say, all parties were just very collaborative. We received very constructive feedback from all the carriers, from staff, and from the OEB members that I think allowed us to create a better product. As we continued to refine that proposal and incorporate feedback, then we identified the next steps. And so let's talk about where we landed on the next slide. So where we landed and the decisions that we made is, like I talked about, we did choose the hemoglobin A1C as the outcomes metric, knowing that this probably isn't going to be the end of our research into diabetes type 2, but it was a great place to start because it's data that's readily available. We also talked through reporting guidelines, and so we developed a series of very detailed reports looking at A1C improvement by different demographic groups, by different types of medications across different populations. And really what we wanted to do is try to identify different factors that could affect success with treatment. And that might be the type of medication that's provided. It might be other characteristics. We also wanted to look at what other diseases might members have that have type 2 diabetes. And so we're using a comorbidity index to try to measure that. Throughout all of our discussion, we wanted to recognize that equity plays an important role. And one of the things that we're really hoping to gain from some of this data is a better understanding of if there are treatment gaps for some populations, and then how we can work with carriers to try to close those gaps over time. If we go to the next slide. And so where are we today? We're expecting the initial reports back from each of the carriers by November 7th. We're currently fielding several questions on technical assistance from each of the carriers, and that's been actually a really good process as well. It's allowing us to continue to refine the reports and make sure that they're meaningful, and then we'll have standardization. We'll have the opportunity to analyze the findings from those initial reports as part of the December board meetings for both OEB and PEB. And then from there, we'll take it back to CAL to recommend next steps. So this sounds like a lot to get to reports, but it's a really complicated topic. We're really excited that this is going to allow us to cut the data in a way that hasn't been done before. And we're really hoping that this is a way that can help us identify action steps that can really move the needle to make sure that more people are being served for the best possible treatment of their type 2 diabetes. So with that, I can pause for questions on the summer research group.
Thank you, Sarah. Anybody has any questions? Why not? I guess we continue to our next item of the agenda, which is the update of COVID vaccine update. We've seen some changes and updates. So without further ado, we'll go to Sarah No, I'm sorry. Margaret, again, hello. There you are.
Great.
Please go ahead.
Yeah, thank you. And I will say Sarah certainly knows a lot about this as well. So she can absolutely chime in if I forget to mention or acknowledge sort of anything. I think first off, just to note, there are a lot of moving parts. So right now there's a lot of activity going on in the COVID vaccine space. We are definitely hearing some questions from members and responding to those. And so wanted to provide an update to the board, as I imagine some of you are probably hearing questions as well. So currently, FDA authorized the COVID vaccination for the 25-26 respiratory illness season. However, they made some updates or changes to the authorized populations. So in the past, where it was really authorized for anyone age 6 months and older, now specifically for the 12 to 65 age group, the authorization is specifically not for healthy adults, but for adults that have a condition that puts them at high risk for complications. And the conditions, there's a pretty lengthy list of conditions that could put someone at risk or higher risk for complications. That first step, the FDA authorization occurred. The next step that would typically occur is the Advisory Committee on Immunization Practices within the CDC would basically, provide their recommendation related to the vaccine. And that would then, kind of kick off the season and vaccinations would carry forward under that guidance. Now, specific for OEB and PEB specifically, so to date, there has been no change in our coverage. So all of the contracted carriers are still processing, any claims for COVID vaccination as they always have. So that benefit is still covered. However, in Oregon, pharmacies are allowed to, under Oregon Board of Pharmacy rules, pharmacies are allowed to prescribe, dispense, and administer vaccinations in accordance with the recommendations of the Advisory Committee on Immunization Practices. Now, the CDC's Advisory Committee on Immunization Practices has not met to make any sort of recommendation related to the COVID vaccine yet. And so because of that, pharmacies can't prescribe, dispense, and administer. So they're requiring that members who call or individuals that, go to the pharmacy and want a vaccine have to have a prescription from their physician. Now, the Advisory Committee on Immunization Practices at CDC is scheduled to meet next week, later next week. Remains to be seen what recommendations they'll issue, but there will certainly be next steps that carry forward from there. The questions we're hearing right now from members are really around can they get the vaccine? Do they need a prescription? The answer is really at pharmacies, yes, they will likely be asked to, provide a prescription, and so they can work with their healthcare provider on that. Specific to worksite flu shot clinics, flu and COVID vaccine clinics that are provided by Get a Flu Shot, which is the main provider that OEB and PEB have long contracted with for any of our entities that want to schedule an on-site clinic. Get a Flu Shot is not a pharmacy, so they are not under the Board of Pharmacy rules. And they have indicated that they have a process for individuals to complete a form. It's basically an attestation form for the individual to attest, that they meet criteria and basically walk through an informed consent process with nurses that provide the vaccines at the worksite clinics, and provided they walk through that paperwork process and provide their informed consent, they will be able to get a vaccine at worksite clinics without having to have a prescription. So there's a little bit of a different process in place there than members would find at a traditional pharmacy. Coinciding along with all of this, of course, the Oregon has entered into or is partnered with other West Coast states in the Western States Alliance. There's been some media pieces related to that. Oregon, Washington, California, and Hawaii have joined together and are going to be developing their own guidelines related to vaccination for the states. So, not necessarily deferring to, guidelines that may come out of ACIP in the CDC. That process is beginning. So we're continuing to watch that closely in terms of how that will have impacts on, access and coverage. And then also, in the Board of Pharmacy, I mean, they're sort of, I think, actively working with pharmacies and considering steps to ensure that good access to vaccination continues for Oregonians. So there is a lot of work in process. I do want to note, there's a lot of unknowns specifically in terms of like operationally what members might encounter when they go into pharmacies in the future. Some of the larger national chain pharmacies could decide to set, national policies that would sort of be experienced by members, uniformly across the country. It remains to be seen. There could start to be variations, certainly by state, significant variation by state in terms of how these practices are put into place. I think we are very mindful of that, recognizing that we do have members that live out of state, more so in PEB than OEB, but certainly, members covered under our plans that may not reside in Oregon. So looking at considerations there as well. So in summary, the COVID vaccines were made covered by all OEB and PEB carriers. And, members seeking those will have to navigate, pharmacy requirements for prescription at this point in time. And then this is continuing to evolve. So we are closely watching it for future developments. And just as sort of a clarification, the flu vaccine, which also becomes available this time of year, that was reviewed by the Advisory Committee on Immunization Practices at CDC back in, I think, the beginning of the summer. I think it was June. It was essentially approved as it normally has been in previous years. So no changes to access for that one. Are there any questions? If you do receive questions from members, please feel free to send them on to staff. We're handling questions and helping members understand their options as necessary. So certainly if anyone comes to you, we're happy to have you send them our way.
Thank you, Margaret. I see no questions, and we are somewhat ahead of schedule. Ali, do we still have 5 board members?
Yes, that's correct. Right? Yeah. Mm-hmm.
Okay, so the next presentation is small numbers and reporting guidelines, but we do have a break between 2:35 and 2:45. So with a thumbs up on your screen or on the camera, would you like to continue with the next presentation or take a break? Next presentation, thumbs up.
Continue for me.
Good. Okay, so we're good to carry on with the next presentation. And we have small numbers reporting guidelines. And that'll be with Christy, with Mercer.
Thanks, Board Chair. Hi, everybody. Nice to see you all today. I am going to provide some information regarding data reporting and an approach that we recommend taking going forward. So if we can go to the next slide, please. And so first I want to share, why it's important to have these data reporting guidelines. And oftentimes what happens when we're reporting on a full population, that disparities in care are masked for different subpopulations. So really important to where it's meaningful to have subpopulation reporting. And so this should have outcomes, engagement, utilization for different groups for OEB and PEB. And again, really aligning with what would be meaningful for CIAO and the boards to take action on. So there are practical use guidelines, and I'm going to share those with you here today, specifically in regards to race, ethnicity, and then also data sets in regards to smaller numbers. These have been compiled mostly from Oregon Health Authority and their Health Policy and Analytics Division, and then also we have the U.S. Measurement and Budgets group that also has provided some guidance. And so, as I said, we recommend that OEB, PEB, and our supporting work groups follow these OHA guidelines moving forward. And really what the goal is that we're improving the health of all members. Next slide, please. All right, so first I'm going to talk a little bit about race and ethnicity reporting. As I said, this is an approach that's aligned with the U.S. Office of Management and Budget, and we also have met with the Health Policy and Analytics Division to talk about the best approach. So right now on our OEB and PEB open enrollment forms, our race and ethnicity questions. And this is where we get this information from when we do our outcomes and utilization engagement reporting. Right now, they're somewhat separate questions, and the recommendation is that we combine them to provide us with the most meaningful information. Also, when we are combining, the other recommendation is that we use an approach that's called alone or in combination. And what this means is that in the open enrollment forms, when somebody would self-report, let's say that they're Hispanic is their ethnicity, and then under that in race, they might say Asian. And so both of those are their self-reported identities. And so we would count that person in both of those groups when we are doing this deeper dive into these different subpopulation reportings. What that means, though, is that members do fall into multiple categories. And so the total members reflected when we do the deeper dive into these subpopulations is going to be higher than the actual population count. You can see here the race ethnicity groupings are as follows. And again, for that specific kind of one that I gave as an example is that member would fall in the Hispanic alone or in combination group, and also in the Asian alone or in combination group. We did talk about this earlier today in CIAO, and there were some questions and concerns that were raised. And so I wanted to share those with you also, that, there obviously everybody's thinking there is some impact to statistics and how the numbers are going to show. Are we putting more, are different groups then not being represented? And, how are the numbers going to look? And how ultimately is that going to basically impact the actions that CIAO and the boards can take? And so Kirsten, in her lovely way of putting things, said, of course, this is new. As OEB and PEB always do, we are pioneers in this and going forward. And, so it's new. We're going to learn. We haven't pulled the data like this before and presented it. And so we will be doing that in November. And so it'll be a learning process, but we will be able to, within those groups, these ones that are here, we will be able to also say, this number of people said this was the race they identified alone. And then also they would be able to say this number of people also identified in multiple categories, so that we are able to really look at what's in there, obviously without talking about individual people's responses, but it would be more to be able to reflect what's in that group. So we could make sure, again, that we're getting meaningful information, but also just want to underline the importance of knowing different race ethnicities is just one example. We also can look at geographic locations, rural, suburban, urban, and those components as well, as just a few examples. So I just wanted to pause for a minute and see if there's any questions or concerns about this approach.
Well, I would just want to acknowledge that in the past, and I know Dr. Laura is not here, but she did mention questions about race and ethnicity reporting. Um, I hope that when she sees this, she's able to continue to work with you and sit with you. I think this hits the mark on some of those questions, but I'll go back and ask her. But for me, I think this looks good on how this part of the identity and race and ethnicity has been captured. I'm sure we can do more to improve, but I think we'll follow with Dr. Lara. So thanks for following up.
Yeah, of course. And we heard, and I think it's a learning process, and it'll continue to iterate on itself as we can evolve the process.
Anybody else has questions? All right. Anything else you'd like to add?
I have a couple more slides. The next one is just talking about the small numbers guidance. And so this does come directly from OHA's Office of Health Analytics. And really, when we're looking at small numbers reporting, there's a balance between wanting to obviously reflect different populations, identities, those types of components that are important when we're looking at data, but we also want to protect confidentiality, and we also have to think about reliability of the information. And so according to these guidelines, then data needs to be released in a way that protects confidentiality, regardless of the data type. Also, when we're looking at aggregating race and ethnicity groups, kind of as I just talked about, it's important to try to use those intermediate aggregation categories versus just suppressing the data. So they really encourage, again, this intermediate aggregation rather than not showing a certain population. And then also, as we're going through, and whoever is doing the analytics work, it's really important to, if there's any identification or awareness of a possible bias in the data, then it just needs to be noted in the presentation. And so the straightforward, standards for reporting on small numbers is that when we're looking at a full count population, and an example is when we're looking at enrollment data or claims data, for protecting population, that the group that we show has to have a denominator, so it needs to be the size of greater than or equal to 50. If a certain group is less than 50 people in number, then we are to suppress that group. And then for reliability, it's really important to know that we can report the values and rates if the numerator of that group is 12, greater than or equal to. And then we put a warning label on the reliability of that information if it were to be greater than or equal to 5 and less than 12. And then if it's less than 5 people in that numerator of whatever the data metric is that we're looking at, then we should suppress the data, and recognizing that it's probably not reliable data. All right, and then I'm going to move to the next slide, which is kind of captures both of these components and a few other pieces. So we know, and using inclusive language and taking action is such an important component and a goal of OEBB. And so consideration for how we're getting the data, how the data is being aggregated, and again, how we're describing the needs and trying to look at outcomes, care gaps for specific populations is so important. And so with that, utilizing the small number reporting guidelines we just talked about, utilizing the alone or in combination approach when we're reporting race and ethnicity, always wanting to make sure that we're reporting on subpopulations, knowing that, again, they can get diluted in a large, if we're looking at a large population. So it's really important to do that for healthcare trends, to look at care gaps, to see these populations that are disproportionately impacted. We also always want to avoid analysis that a privileged population is normal or desirable compared to others. We want to encourage you avoid using the term of BIPOC and instead use the name of the group. If it's multiple groups, at least spelling it out rather than using an acronym. And then avoid using the grouping term of other, naming the subgroups that are in a group that's being used, or using a more descriptive term that really captures that grouping. One suggestion is people from racial and ethnic minority groups. And these are following the OHA writing style and equity-centered communication guidelines. And really the thing here about other is that using termination, some of the other terminology that's used for different race and ethnicities is more descriptive of that race and ethnicity, whereas other is not descriptive, and it doesn't feel really good to be put into an other category. So we really want to name, recognize, and be responsive to whatever groups are in a certain category that we've aggregated in order to protect confidentiality or reliability of the information. Any questions on these guidelines? All right. Well, thank you, everybody. I appreciate your time.
Thank you. And if there's any other follow-up questions, we can email the chair or directly to Ali, and we're happy to follow up. All right. So we're doing so good on our first meeting of this year that we're ahead of time. So it's not going to be always the norm, but we did really good the last time too. We finished on time. The next part is the OEB new plan year kickoff. And we have Team Mercer with John and Kristen to present. So I guess without further ado, we'll continue with the agenda, and maybe we leave early and get an extra time for our break. So go ahead.
Yeah, thanks, Board Chair. Welcome, everybody, to the new plan year. We are really excited to come back and get started with you, as the cover title of our presentation indicates. Let's go on to the next slide, please. I know we've said this about 1 million times by now, but we really like to start off conversations like this just by anchoring to OHA's mission and vision, and then OEB's goals that we set with you last retreat. As Christy mentioned in her presentation around small numbers reporting guidelines, OEB really is a pioneer in transforming healthcare in the state of Oregon. And we work closely with Medicaid and also PEB in some situations, especially clinical ones, for example, the Summer Research Group, to advance healthcare in the state of Oregon. I know we've mentioned this before, but between Medicaid, PEB, and OEB, we have 38% of the Oregon population represented. So it's a tremendous opportunity to help OHA achieve goals which really benefit everybody. And that's the first bullet here: help people in communities achieve optimum physical, mental, and social well-being through partnerships, prevention, and access to quality, affordable healthcare. So truly, it is a partnership with everybody to be pioneers and transform healthcare. And then there's some definition of what healthcare transformation includes here: improving the lifelong health of Oregonians, increasing the quality, reliability, and availability of care for all Oregonians, lowering or containing the cost of care to be affordable to everyone. And we'll talk about that more throughout this entire year and come back to it as we talk about different decisions that we have to face. Performance guarantee credit, for example, being used to offset the renewal increase if it comes over 3.4%. So we avoid conversations around deductible increases. So it's a live example from today. The vision for OEB is that we will work collaboratively with districts, members, carriers, and providers to offer value-added benefit plans. And Sarah Drake really highlighted the collaborative effort between OEB and PEB, board representatives, our carrier partners, OHA staff, and Mercer to integrate type 2 diabetes outcomes metrics into the work that we do to try to improve treatment and also try to be innovative in provider payment. That's kind of phase 2. And then also incorporate outcomes into treatment guidelines to improve the health of all Oregonians long-term as part of phase 3. beginning with reporting now. So another live example of this in action today. The vision asks that we provide value-added benefit plans that support improvement in member health status, hold carriers and providers accountable for outcomes, provide affordable benefits and services, support Oregon's health system transformation efforts, embrace the coordinated care model, CCMs. We've already talked about a lot of that today. Let's talk about OEB's goals actually on the next slide, please. And this is a layout for OEB's goals that you'll see. We've used this with our previous goals, and you'll see this slide and know immediately when you see these rings that we're talking about OEB's goals. And these are goals that you set in November of 2024. It's all a blur, isn't it? In November of 2024 at the retreat, we set goals on a biannual schedule with you. So in the upcoming November retreat, we will not be choosing new goals, but just reaffirming and deciding how we want to go about achieving these goals again in the upcoming plan year. And they are high quality, affordable care. It's hard to have a goal lineup that does not include that goal because it's so integral to OHA's mission and our vision for OEB educators and assistants. Grow OEB. We're going to hear from Georgianne at a later point in the board agenda this year around growing OEB and adding more special districts or new entities to OEB to really help keep our population fresh and to increase that 38% so we have even more leverage within the state of Oregon. Reduce out-of-pocket expenses for our members. This has been a tough one in our economic climate. It's going to continue to be a tough one. And we are going to continue to look for creative ways to keep healthcare as affordable as we can for our members within the constraints of the 3.4% mandate of Senate Bill 1067. We did hear you last year when you asked us to think about the value of an RFP for OEB, and that is on the agenda coming later this year to talk more about the role of an RFP and what would OEB potentially gain from that. Member education is another long-standing goal. It was a carryover from the prior goal cycle. And again, it's hard to have a goal lineup without member education. And it's going to be wonderful at a future agenda, board agenda session to have Cindy and the communications team, Sarah Berthume, Mercer communications team. They have been working so hard on behalf of your OEB members to build out, along with your carrier partners who've been traveling the state, building out communications and routine OEB open enrollment materials, but also many special ad hoc open enrollment supplements this year as well to help members understand the changes that are taking place and then also understand the role of Garner. So big shout out to everybody for their hard work, and also to our OEB educators and assistants themselves for making good use of the OEB open enrollment materials. Next slide, please. We wanted to just, as we head into the start of the new plan year, and it's September 9th, so actually for OEB, we haven't even started our new year yet. We thought we would just level set on what we accomplished in the last renewal together, acknowledge some of the changes that took place as we head into the next start of the plan year on 10/1. In terms of member education, I talked about this at a little bit of a high level, really has just been focused on helping our members understand the suite of changes. Some of them were, harder than others, and help them really be empowered to choose the best plan for them. Some of the member education highlights include monthly newsletters and events, often featuring a specific clinical condition to really rally our membership around the tremendous array of services that we offer. John and I are often asked to review the monthly newsletters before they're published, and it's astonishing the number of services that are available to our OEB members, and it really highlights for us that our challenge in improving healthcare is not so much adding different or new things, but it's in connecting members with the services that we already have. There's a learning platform called Explore Your Benefits. There are the health plan summaries. Those are available online. Feel free to spend a free evening searching those if you like, including an online plan comparison tool that's been laid out so well by staff in Mercer that even our core consulting team will often Google OEBB plans and use that plan comparison tool. A benefits and wellness guide, vendor presentations, open enrollment materials, including home mailers, webinars, rate sheets, and then a presentation to the insurance committee and along with a renewal summary. So just a tremendous amount of work kicks off the minute that our board wraps up with the April decision meeting. In terms of providing high quality, affordable care, I'm going to talk about this in conjunction with reduced out-of-pocket costs because that really was a partnership effort between these two goals last year and really was a give and take between everybody involved with the renewal this year, you board members and your constituents as well. As we dealt with a high renewal increase and tried to bring our renewal down to 3.4% in the best way that we could for our membership while always trying to achieve our goals. Feels like with healthcare, we're always trying to do many big things at one time. But we added Garner plan selection tool effective 10/1, and I know many of our open enrollment materials and now this conversation with you, and you'll hear about Garner more throughout the year, really trying to spread the word to our members to enroll and use Garner because their out-of-pocket expenses can be reimbursed up to the Garner incentive maximum if they seek care through a provider that has been identified by the Garner tool. MODA also had a site of care initiative too that helps steer members to high quality, affordable care. We were able to make some inroads in reducing out-of-pocket costs, even though I do want to acknowledge that we had to make some significant deductible increases in an effort to reach 3.4%. So I don't want to gloss over that or make this seem like a sales presentation. It really is trying to look at the whole picture and that we were able to accomplish some wins given the climate that we had. And that was the Garner program, again, reimburses some member out-of-pocket costs up to the limit that you see, $700 for individuals, $1,400 for families. We reduced the family deductible and out-of-pocket maximum on the MODA plans. Kaiser also, those were set to be 3 times the individual amount, and now they're 2 times. So for families who are, needing care and bumping up against that maximum, that will be an improvement for them. Kaiser will include artificial reproductive technology up to the current benefit limit and also will remove the bariatric surgery additional copays. That was an additional $500 on top of the traditional benefit. Kaiser and MODA are both going to waive supplemental imaging. That's part of breast cancer detection in the HSA plans. And then MODA has implemented the Epicor site of care program. So many efforts to try to make our plan more efficient and connect members with high quality care, reduce out-of-pocket expenses where we can as well. Pause there and see if there are any questions, and then we can keep going.
No questions, I guess we'll keep moving.
All right, next slide, please. Thanks. I'm going to hand it over to John for the rest of the presentation. Thank you.
Welcome back, board members. We're going to hit upon some major kind of global factors here, environmental factors that are impacting not only the OEBB plans, but the economy and healthcare in general. So we're kicking it off with a quick discussion of the One Beautiful Bill Act, which is how HR1 is commonly known. And what this does is really in one bill executes much of the president's agenda. And this agenda includes permanently extending the 2017 Tax Cuts for both individuals and businesses. It also includes temporary tax policy changes related to tips, overtime pay, and senior income. And it also increases funding for border security, immigration enforcement, and defense. So the question becomes, how is this being funded? And Bill, I think this probably gets to some of your question. This is being funded partially by reductions in Medicaid. And these reductions in Medicaid are coming through changes in the eligibility rules, the implementation of work requirements, and also cost sharing requirements. So this is partially how this is going to be funded. And I think, Bill, now I want to try and get to your question, which I think was, how is this going to impact the broader healthcare system? And, again, this could have pretty serious impacts, because what happens is, as people lose their Medicaid coverage, they still need to use services. So what happens is those services become what's known as uncompensated care from a provider perspective. And historically, what providers have done in this situation is something called cost shifting, which is the cost shifting is when essentially commercial members like the OEB members are charged more to offset uncompensated care, as well as lower reimbursement that providers get from Medicaid and Medicare. So the thing is, ultimately, this could result in providers, this creates and there's already a lot of financial pressure on providers, particularly in Oregon. This creates additional pressure on them financially. In response, they may, choose to reduce the range of services they offer, or take other measures that might reduce access to care for everybody. So the thing is, I think the point is to understand is, when you reduce Medicaid coverage, it really impacts everybody, not just those who are on Medicaid. So any questions? And Bill, does this get at your question, hopefully?
Yeah, it starts. I was kind of wondering what Mercer's opinion was on how long it's going to take for some of these offset costs to start rolling through the general system.
And I think that depends on, how quickly people are coming off the Medicaid rules. And and again, I think that's going to differ in different states as well. Go ahead.
They can't, well, they're going to transfer it. He was too hard to understand. So they're going to, I need everybody's AMP or whatever, IMA numbers. So what it sound like he's saying, or
IME.
okay, I couldn't tell what he said. I need all those to be able for them to send over.
I'm not sure if that is that a question.
This doesn't sound like the board meeting. So sorry about that.
Right. Go ahead.
I didn't want to interrupt anybody though.
Go ahead, John.
Okay, so Bill, hopefully that kind of helps you understand the broader consequences of these actions. In terms of the timing, I think it's really anybody's guess, and that I think it will roll out over the next year.
I'm just thinking about the upcoming renewal, and if some of those are going to be happening during the renewal, or we'll know more before the renewal.
It will probably happen during the renewal.
That was what I was hoping not to hear.
Yeah, sorry. Any other thoughts, questions? The other thing I just want to touch upon about in terms of the One Big Beautiful Bill Act, is that there are also some very interesting benefit-specific provisions. And I'll just give you a quick example. There are several of them. I think the example that's probably most relevant to the OEB population is that during the pandemic, you may recall that there was an exception made for telehealth for members on HSA plans. And OEB has some HSA plans, and what this allowed them to do was a kind of a temporary exception that allowed them to access telehealth services without first having to meet that large, HSA qualifying high deductible health plan deductible. So, that was sunsetted, fairly recently. And then what the big beautiful bill did is actually reinstate that permanently. So I think that's a good example of some of the benefit things that came out of the One Big Beautiful Bill Act.
All right. Thank you, John, for presenting this. Go ahead.
Oh, there's still more. This is just the first slide.
No worries. It's a beautiful slide. I'll tell you that.
Any questions on this, Enrique, or are you good for us moving along?
And
I wish I was bringing better news too. So again, this is kind of challenging. So moving on to the next slide, and this will tie in with Margaret's discussion earlier about some of the cost increases. And I'm not going to present so much the information on this slide. I'm going to talk about a broader survey. So this slide is really the kind of pulse survey results that we did at Mercer in the middle of the summer. And over the last week, our major survey results, at least some preliminary results from our major survey have been released. And I think I'd rather speak to those because it's a larger sample. So at this point, the preliminary results are based on 1,700 employers responding to our survey. And frankly, the news is challenging. So basically, employers expect the highest health benefit cost increase in 15 years. So, so what does that mean? So I think they're expecting, and this is on average, about 6.5%, and that's after the cost reduction measures. Before the cost reduction measures, they're expecting around 9% on average. And this is about after a decade of moderate annual increases. I think everybody remembers that decade, averaging around 3%. But 2026 is the fourth consecutive year where we've seen elevated increases in health benefits. And not surprisingly, there are two kind of key drivers around these increases. One are prices for healthcare services, and the second one is utilization. And I'll touch upon, again, this is not going to be an exhaustive discussion, obviously, but we're going to touch upon a couple of the key drivers. In terms of the price drivers, not surprisingly, again, it's advances in diagnostics and therapeutics. And these advances, tend to improve the results, the outcomes in care, but they tend to also be more expensive than the treatments that they replace. And this is really where healthcare differs from a lot of other industries. Like in most industries, technology helps to reduce costs, not so in healthcare so much. One of the other key factors that you're seeing in healthcare is, provider consolidation. And that means that you have fewer, larger health systems, which gives them, better leverage in negotiating with the reimbursement levels with the insurers. And I think the other thing too, another key driver on the prices is really just general inflation. And you've seen that in the broader economy, and that impacts the healthcare economy too. And you see that as pushing up wages. I'm going to also briefly talk about utilization, and some of the key factors there are still related to the after effects of the pandemic. So over the last 2 years, we've seen kind of lingering effects of the pandemic in terms of delayed or missed care that is being caught up on. And then some other key factors around driving utilization are, the improved supply of labor supply. So there's, more providers available. And so people are able to get their services that they need more easily. And you've seen that even in your own plans, such as Kaiser. And the other thing is really consumer acceptance of things like virtual care. And what virtual care does really takes geography out of as a factor, as a constraint of receiving care. To close, I want to touch briefly on, because I think the board will find this interesting, I'll touch briefly on some of the things employers are doing to address costs. And OEB is already doing, the board is already doing some of these things, but some of these might be also food for thought. And again, I want to also move beyond just plan design changes and increasing contributions. Again, that's, many employers are having to resort to those types of things. But I think the other interesting things are, a greater focus on managing high cost claims, measuring the programs, the health programs that you offer to ensure that they provide value. And I want to tie this to some of the work that's already occurring in CIAO, particularly around, diabetes care and, the value that point solutions are bringing. So Rob's presentation from CIAO this morning was, on some of those topics. Another thing that employers are doing to address these increasing costs are really addressing high cost claims through case management and other means. And then what you're also seeing is a stronger focus on programs designed to support members with chronic conditions. Because one of the things that's very much true in healthcare is that typically what you see is a relatively small amount of people driving most of the costs, and you want to make sure that those people are getting the care they need when they need it and where they need it. So let me just pause there, and that was a lot of information. And you see if there are any questions or comments. Okay, well then we'll move on to the next slide. And our purpose here is really just to give you a preview for the year ahead. So we are in September and kicking things off, and in October we'll have the cost and utilization presentation, and that will be on an overall view level. And then in November, as you know, we'll have the retreat, and the retreat will be focusing on setting strategy and goals for the renewal. And during that, we'll also hit upon more on the cost and utilization and looking at some of those subpopulations. So we'll be employing those small numbers rules that Christy has touched upon. So they'll come into play when we prepare the data, the cost and utilization data for November. Then December is really, we'll have the plans in, so they'll talk about innovations. We'll also be drafting and sending out the renewal letters to the carriers. And those renewal letters typically come in, right after the first of the year. And so, January, we won't have the results of the renewals in ready for that meeting, but they will be ready for the next meeting in February. So, February through April, that's pretty, that is when the board is in the zone, really, so to speak, right? So the thing is, February, it's really understanding the results of round one and preparing for round two. When we go into March, it's really looking at round two results and, seeing if there's a need for round three. And then really April is the decision month. So really making those tough decisions, and then, the renewal summary in May. And then while the board takes a break during the summer, CIAO is still in session. We have the CIAO Summer Research Group. And then also a lot of staff is very busy during the summer, and as is Mercer, around communications and contracting to get ready for open enrollment in August and September. So that's really the year in a nutshell. We just thought it would be good to give you a quick preview of that. Anything that you wanted to add, Enrique, as we as we kind of look ahead?
No, I look forward to all of us to continue the discussion, and I do like us to get those friendly reminders on how the policies in Washington, D.C. are going to impact Medicaid and our renewal process. Obviously, we know it's going to be more expensive, and I think that all of us should be in tune on how if any changes occurred. We should have that update on the next board meeting. And also, I think, again, for those who worked on the equity lens, I do have a question, but that's for later on the BIPOC terminology, but I think we have to be prepared for some, for members of the public or any members who might have questions why not have that name on the materials. And overall, I feel good. So thank you. If any board member wants to add anything else, feel free to do so. All right. So this is our timeline for the rest of the year.
Yep. And then the next slide will just wrap things up. So we just want to be upfront with the board. We think that there's likely to be another challenging renewal season, similar to the last 2 years as well. To your point, Enrique, we also think that health equity has to be, held in our minds as we go through this process and make, continue to be a priority. One of the other things that we want to highlight, for the year ahead is really monitoring Garner and really just both from an employee experience, from the member experience, and also in terms of the outcomes, in terms of the savings that they're generating, to see if those are on target. And then what we'll be doing during the fall is really, as part of the process in October and in November, is really looking to identify new conditions where there's a need to close care gaps. So I think that's one of the very positive things that has come out of the board priorities and the retreats over the last couple of years is really, active with the board actively seeking to ways of closing these gaps in care. So, Sally?
Sally, yeah, go ahead.
Yes. I just want to kind of put this out there, right? Prior to any renewals and anything like that, to our insurance carriers, that I was appointed to this board to represent classified employees, right, throughout the state of Oregon. And I work for 4J, and the average salary here at 4J for classified employees is $35,000 a year. Okay. I really want our carriers to keep that in mind when they are coming up with those renewals, those rate increases, that I really am, I'm representing the lowest earners and who work really, really hard for our students. And large rate increases greatly impact them, right? They are at the poverty level. So just please keep that in mind. I really encourage you to, we've had a couple really hard years. This one was especially hard. I am the face to employees as their benefits coordinator. I meet with them face to face. I do the benefits presentations. I go to the departments. I help with open enrollment. I just really encourage them to for this year, and I'm not saying they don't typically, but to really put the people before profits this year. So.
Thank you. Well said. So that's the end of this part of the presentation, the new plan kickoff. And then for our next item, we have public comment. And do we have anybody who wishes to speak, Ali, online?
Yeah, we have three sets of public comment. Two were related to the Kaiser Gender Affirming Care Services, which I can give some background on, and the other was related to GLP-1 drug coverage. Do we have Ms. Wagner? They submitted public comment related to GLP-1 coverage. Okay. So Enrique, I can give some background on the 2 letters related to Kaiser, if that's okay with you.
That's great. Thank you.
Yeah. And first, definitely like to thank those who took the time to put together and submit public comment to the board. We, the board really values that, and oftentimes that leads to a lot of discussion and even action on items submitted for public comment. But the 2 letters addressing Kaiser's gender affirming care announcement were also submitted to the PEB board. And to give you a little bit of background, on July 23rd this summer, Kaiser notified OEB and PEB that Kaiser's providers will be pausing gender affirming care surgical procedures for members age 18 and under at their facilities effective August 29th, so just in the last week. And they're actually referring those people out for the procedures to providers outside of the Kaiser facilities. So there's not a denial there. It's a referral out, but there are currently no OEB nor PEB members age 18 or under awaiting procedures fitting that criteria. So Kaiser is continuing to provide all non-surgical gender affirming care treatment for those 18 and under. For individuals 19 and over, all gender affirming care services remain available. So this is a provider-driven decision. This is not a planned coverage restriction or denial. So in states such as Oregon, where medically necessary gender affirming care is mandated, Kaiser plans will continue to cover surgical treatments delivered by qualified external providers. So staff and Mercer have been in close contact with Kaiser on this, discussed this with them, submitted some questions, and they've been communicating with their members about this change. So we'll keep the board updated and encourage you to read those public comments, and yeah, we'll keep the board updated as changes occur.
Thank you, Ali.
Yeah.
Do we have anything for the good of the order? Again, we were not able to adopt the minutes from our previous board meeting. And also,
we do have Tony Mann just joined. If Tony, that would give us a quorum there.
Great, we have quorum. Tony, where are you? I don't see you on my screen. Well, hello, Tony. Welcome. And hello, Bill. Hello again. And so I guess we have quorum. I guess without objection, can we go back to the action item that we were presented earlier from Margaret and Kirsten? I think will be good for Tony. I think he was present during that item, and then we can take formal action. Well, I guess first of all, let me go way back. I got to go look at the minutes, adopt the agenda with flexibility, and then we'll go to Kirsten and Margaret. So all of you received the minutes from our board meeting. Are there any edits or corrections that need to be made? All right, so without objection, can we accept the minutes as presented? Perfect, thank you.
I'll move that we accept the minutes as presented.
I'll second. Thank you, Robert. All those in favor to adopt the minutes as presented said aye or thumbs up.
Aye.
Thank you, Sally. Motion carries. And now we're going to officially adopt our agenda with flexibility of September 9th. All those in favor to adopt the agenda with flexibility. Well, I need a motion from the floor.
I'll move. Sorry, I forgot what we.
We're adopting the agenda.
I just realized I was thinking of the C-out meeting. What was?
For our OEB meeting today. Because we need to take an action item on one of the presenters' report.
Yeah, and it had to do with the budget. It had to do with the reallocation of the fees to go back to. It was option 1, reallocation of the fees to go back to the carriers for reducing the rates.
Correct.
If
So
I could see that, I'm trying to pull up the slide here so I say it correctly.
We have to adopt the agenda for September 1st, and then we can go into the action item. So I need your motion to be to adopt the agenda with flexibility for today's meeting.
Oh, I see. So so I move that we adopt the agenda that we just completed, sort of, with the adjustments as presented.
Second.
Thank you, Sally. All those in favor to adopt the agenda with flexibility as presented, say aye or thumbs up or hand up.
Aye.
All right, motion carries.
And just so the minutes are accurate, I'm not the one who seconded that.
Oh,
I'm
who was
sure
that?
who was, but
Susan Miller.
Okay.
Susan Miller,
Susan.
thank you very much. Great to see you or hear from you, Susan. All right, so can we go back now to Margaret and Kirsten's performance guarantee update, because this goes back to what Bill original's motion was, and then the reason why I want this to be this way is so all the board members who sort of join towards the end can have the presentation and information available, so we're all on the same page. Thank you.
Yeah, absolutely. And Rose, is it possible to go back to page 14 of the PDF packet and put that up on the screen?
I don't know what page 14 is.
Oh, in the PDF, it's the the trend guarantee update.
Mercer slide 2 within that presentation, I think. Is that the one you're looking for, Margaret? Role of performance guarantees?
Yes. And what I actually have is I just have the PDF binder up. So that's what I was referring to in terms of page 14, but your pages might be numbered differently, Rose. I apologize.
They are. So tell me when I get there.
Okay.
We don't see
think you're sharing.
I'm not seeing it yet.
Okay, you're talking about trend guarantees? Oh, I'm not sharing. That would help, wouldn't it?
Yeah, keeps it interesting.
Yeah, okay. Okay. Yeah.
Yes. Yeah. So if you could go back maybe one slide. Yeah. Okay.
That one?
So I guess I'll check with the chair. Enrique, would you like me to do just a really quick overview for the benefit of Tony, since he missed or wasn't here for the longer discussion?
Yes, high level. I think
Great.
that will show that we're being transparent and good fiduciaries to our public, to our members. Thank you.
Yeah, absolutely.
Oh. And thank you everyone for your grace on this. I appreciate the pause.
Yeah, absolutely. No problem at all. Happy to do it. So today, specifically, the decision we're looking for from the board is related to the financial performance guarantees that OEB has in our medical carrier contracts. And specifically, that guarantee, you'll see it's the third column on this slide. It places 5% of medical plan administrative fees at risk for keeping cost growth in line with the 3.4% statutory cap that OEB has to meet in terms of year-over-year program cost growth. And so the way the guarantee works is the carriers place 5% of their administrative fees at risk. If plan cost growth is 3.4% or less, then there is no penalty, no fees at risk. Carriers retain all administrative fees. If the cost growth is more than 3.4%, but up to and including 4%, then there's a 2.5% of administrative fee penalty associated with that level of cost growth. And if the year-over-year cost growth is 4% or higher, then the full 5% of administrative fees penalty is due back to OEB. And so today we're specifically looking at results from the 22-23 OEB contract year, comparing it to prior. And so Rose, if you can advance to the next slide. Sorry, and I will correct that. We are comparing 23-24 to the year prior, which is 22-23. So it's year-over-year growth for the 23-24 contract year. And in terms of the results, both carriers, both Kaiser and Moda, exceeded that 4% level. So they both owe OEB the full 5% of administrative fees penalty. And that equates to the dollars amounts shown in the center column. For Kaiser, it's just over $720,000. And for Moda, it is 1.99, just over 1.99 million. So just under $2 million in terms of the fees at risk due. In total for both carriers, it's 2.71 million. And you can see in the last column on this slide, just for reference, the results from last year, from the 22-23 contract year settlement, are shown there. And similarly, for that year, both carriers also owed the full penalty, and the total was just a bit under 2.6 million. Next slide. And then also, so to recap in terms of putting this into context, and we talked a little bit about this as well in some of the other presentations today, but the link at the bottom of the slide shares the most recent report from Oregon's statewide healthcare cost growth target program. That report looked at cost growth from 2022 to 2023 for that year. And high-level findings on this slide, statewide cost growth in that report was 5.2% on a per-person basis. And for commercial market, total medical expenditures grew 6.3%. And lastly, no commercial payers met the state's 3.4% cost growth target, as measured, in this report by the Cost Growth Target Program. So this is just sort of in thinking about the context. OEB plans operate in the commercial market. OEB offers commercial coverage. This is, I think, not unique to OEB. It's something that's being seen market-wide and statewide and nationally. In addition, this report from the Healthcare Cost Growth Target Program includes data on observed cost growth in Medicaid and Medicare as well. So looking at all of the market segments. So it's included there in the footnote for your reference if you're curious about that. Next slide. All right. And I'll pass it to Kirsten here to walk through the specific board decision.
Yeah, thanks, Margaret. Tony, we were just contemplating in this slide how the board wanted to receive the money that it's owed from Moda and Kaiser. There are two options, and one has some advantages to OEB, which is why it's starred. But you might remember from last renewal that there's a pool of reserve funds called the Rate Stabilization Reserve. And sometimes we use it to help buy down the renewal to reduce the final renewal increase to get down to 3.4%. Sometimes we use it to fund clinical programs that we think will help reduce claims costs as well. But it has some administrative cost associated with it, not financial costs like time and resource cost. And also the discussion around rate stabilization reserve comes at the very end of the board renewal season. In the March meeting, we might start talking about it and then make a decision about it in April. So if we wait until April to make the decision to apply that credit to the renewal, that means all the way up until April, we've been talking about, we've been looking at a renewal increase that did not have the credit applied, which is going to be higher than ultimately it would be, which means we'll be talking about more changes than we need to be talking about. So it's Mercer's recommendation to have the carriers apply the credit right at the beginning of the renewal process to the round one renewal increase. And that way, what the board sees is the lowest possible round one renewal increase This is consistent with the approach that we've taken in the prior couple of plan years as well. And then it saves a lot of accounting and contracting headache on OHA and MODA's part, which is beneficial to the board, because that's time that people can be spent doing other more meaningful things. So the decision here would be, if the board wants to make one, whether to go ahead and endorse option 1 over option 2.
Oh, go ahead.
So Tony, as I pointed out earlier in the meeting when we were discussing this, so the last few years I've always advocated for option 1 as the most efficient, and in this case of the last couple of years with the way healthcare costs is going, gives us the best results in getting to the final cost control measures that we need to do as a board. So by doing this now, it allows that efficiency and what needs to be done. We're going to be high this year, in my opinion. That's Bill's opinion there, but it's kind of obvious what's going on at the federal level, that these costs are going to be high. So we need to drop this into the round 1 now as far as getting this into a place where we'll get to success much easier. So I advocate for option 1. If you have any questions on that, deeper,
so
kind of a high level statement.
So, Kristen, you're done with your presentation, because I hear Bill has a motion on the floor, but do we have any?
Not yet. Just wanted to see if Tony had anything else he wanted to learn, as we did earlier in the meeting.
Go ahead, Tony.
Yeah, no, I appreciate the additional sort of historical context, Bill. And I don't think I have any follow-up questions at this time.
In that case, Chair, I'd like to make a motion that the board adopt option 1 for the fees at risk for this coming year to be used in the round 1 negotiation as a return.
Do you have a second?
This is Robert. I'll second that motion.
Bill, would you like to speak to your motion?
Nope, I'm good.
Any further debate on this? All right, I'll put the question to you. All those in favor to adopt option 1, apply towards the 2026-2027 renewal increase for Kaiser and MODA in round 1, if renewal increases are greater than 3.4%, consistent with historical approach. All those in favor, raise your hand or thumbs up or your emoji.
Aye.
Say aye. Looking at the screen, motion carries. Thank you, Susan Miller. Motion carries. We have adopted option 1, and that's it. Any questions for the good of the order or remarks? Okay, we're done with the first meeting of the year. Thank you to staff, and thank you to the board members, and also to Ali, and also our members of the public who provided testimony. And we'll look forward to seeing you on the next board meeting. And welcome back, Bill. Welcome, Tony. Good to see you, Robert. Sally, great to see you, and Susan, and everybody else. Have a good day. And anything we'd like to add, Ali?
No, thanks everyone. I know it was tough time in September to get together, but appreciate it.
Thank you. All right, bye.
Great job chairing you, Enrique.
Thank you. Appreciate it.